Good afternoon, everyone. Welcome to our today's webinar. And today we are going to talk about Kaposi Sarcoma in Uganda, current trends and experience. And we have Dr. Stephen Mirembe and Dr. Miria Cherop. So Dr. Miria Cherop is a dedicated medical professional, currently serving as a second-year resident in dermatology at Mbarara University of Science and Technology. She has been a medical officer at CK Uganda since 2018. Where she continues to provide expert healthcare services. Dr. Cherop also gained valuable experience as a medical officer at Doctors Hospital Seguku between January and September 2018. She earned her medical degree in 2016, and her career reflects a strong commitment to advancing her expertise in dermatology while actively contributing to the healthcare sector in Uganda. And Dr. Stephen Kizito Mirembe is a graduate of Mbarara University with a master's degree in medicine in dermatology and added training in allergology and occupational dermatology from Heidelberg University in Germany. His experience as a dermatologist spans over a period of 10 years. He has actively participated in supervising hundreds of students at both undergraduate and postgraduate level. He has published various occupational dermatoses from studies done both in Uganda and in Germany. He has also various works on pityriasis rosea, hemangioma, and neonatal dermatosis, among others. He has lectured in various universities as full-time, part-time, short-term, and adjunct lecturer. These include Kampala International University, Equisat University, Busitema University, and is currently the head of dermatology department at Mbarara University of Science and Technology. So our hosts today are me, Salvanikis, Fortunate Raymond McCoy, and Sibali Gibu. So who are we? We are the GLODEM Trainee Committee, and we deal with the international, and we are under International Foundation of Dermatology with the long form of International Alliance for Global Health Dermatology. We aim to promote knowledge equity by improving access to the educational dermatology trainees across the world. We aim to provide free educational events and opportunities to build network and collaborate. So a little bit of housekeeping rules. Your audio will be muted and your camera will be turned off for the duration of this webinar. If you have any question or comments, please submit via the chat function or Q&A button. Our meeting host will share this with the speakers to answer at the end of the webinar. We will be sharing further information about the GLODEM Trainee Committee in the chat function. So now I welcome our hosts, our presenters to take over.
Okay, good afternoon, colleagues. Good morning to those in the United States, and good evening to where it is relevant. I welcome you all to this session, which we are going to present with Dr. Miria. So, and the first part of this section is going to deal with a review of some of the key or unique cases that we have seen in the last few months, and then subsequently we shall discuss Kaposi Sarcoma with key interest in the experiences that we have had here at Mbarara University in southwestern Uganda. So I'll invite Dr. Miria Cherop to start the cases as presented.
Thank you, Dr. Mirembe, and thank you to GLODEM for giving us this opportunity to present our work. So I hope I am loud and clear. Okay, so as Dr. Mirembe said, we're going to be looking at Kaposi Sarcoma in Uganda, the current trends and experiences. So as we're going to see, we have about 4 patients, and these patients were seen within the last half of last year, I think only for most of them anyway, and one was seen earlier last year. So we'll start with our first case. This was a 33-year-old male who presented to our clinic. He was HIV seropositive, and he had been on his ART regimen, that is TLD, for about 5 months. And he had, at the time he came to us, his CD4 count was unknown, but he had reported adhering to his drugs. He had also been on anti-TBs for about 4 months. So this swelling, he reported, started from his, yes, excuse me. Yes, so this swelling started from his limbs and later progressed upwards up to the groin, and also involved the penis and scrotum. He had also noticed some swellings that he said were dark in color over the groin, thighs, and the trunk, but they were not painful or itchy. So he had gone to a traditional healer for treatment, but he reports that there was no improvement. So in the review of other systems, it was unremarkable. He occasionally drank alcohol, and he was a non-smoker. And there was no family or personal history of cancers. So on examination, he was a middle-aged male. He was sick-looking, wasted, febrile with mild pallor. We also were able to palpate left inguinal lymph nodes, and he had bilateral lower limb pitting edema. His vitals were normal, except the pulse rate, which was slightly elevated. And at the time he came to us, he was about 60 kilograms. So on examination of the skin, we noted black macules and patches. We also saw plaques. I'll just take us a little bit ahead so that we can have a look at the images as I do a running commentary. So as we can see in the first slide, he was clearly wasted, and on the trunk, not very clear, but we have on the abdomen and chest, we had some black macules and plaques. Then also, as we can see on the brain, we have the penile swelling, the scrotal swelling, and those nodules and plaques and macules at the brain. Okay. So also on examination of the chest, we were able to pick out it was done on percussion, and we had inspiratory fine crepitations on the right infra axillary and basal areas. So we came up with the diagnosis of epidemic Kaposi Sarcoma, and with differentials of lymphatic filariasis, deep fungal infection, and bacillary angiomatosis. So we took off a punch biopsy. So as we can see from the slides, from the histology slides from the punch biopsy, on the first slide, that is of low power, we had a normal epidermis with the basket weave pattern of the stratum corneum. The granulosum was present with normal spinosum and stratum basale. So it's on low power, it's not very clear, but when you go to the next image, that's when we may appreciate the vast endothelial proliferation. I don't know if you're able to see my cursor. So from here, we can see the vast endothelial proliferation together with this extravasation of red blood cells. And you should be also able to see these slit-like vascular spaces lined with endothelial cells. So there are quite many of them, Yeah, so you should be able to appreciate that. So on the next slide, still same thing, lots of extravasation of red blood cells, the slit-like vesicular spaces, and we should be able to appreciate some of the spindle cells. So these slit-like vesicular spaces are lined by spindle-shaped endothelial cells. So you can see one there. So still same thing that we are seeing on this other next slide. Okay, so we confirmed case using the biopsy, and then there were other tests that we also ran. So as we can see, his CD4 count was at 13 cells per microliter, and his serum CRAG was negative. For the CBC, there was a slight leukopenia with a lymphopenia and an elevated MCV. His renal function test, we had a slightly elevated creatine level, but the liver functions were normal. Then also on chest X-ray, there was a homogeneous opacification of the bilateral mid and lower lung zones, a bilateral apical pleural thickening, prominent horizontal fissure. And for the chest ultrasound was also done that showed a right pleural fluid, left lateral pleural thickening. And we also did an abdominal ultrasound scan that showed segmental large bowel thickening with mild ascites. So for treatment, so usually after we've done the lab investigations, we send these patients to the oncology unit of our hospital. So there they are reviewed by an oncologist who prescribed IV paclitaxel at 100 milligrams per square meters. This was 6 cycles of these were prescribed, with 1 cycle every 3 weeks. And the pre-medications that were also prescribed were IV dexamethasone, metoclopramide, ondansetron, and oromorphine. So this patient so far has received 2 cycles of the chemo. He has no complaints so far, and he has actually added on some bit of weight, about 7 kilograms. So these are his current pictures. As we can see in the groin, initially we had a lot of the plaques, the patches. They seem not to be very visible now. And as we note here, the edema seems to have increased, but it was because this picture was taken late in the evening. He says usually the swelling tends to increase when he sits for long. And the back, as we can see, some of the plaque-like lesions are flattened. They are more like patches. Okay, so we go on to our second case. So our second case similarly presented with lower limb swelling, in this case, the right lower limb. He was a 55-year-old male, non-hypertensive for the past 3 years. This swelling had been going on for about 2.5 years. So it started from the foot and of course progressed all the way up to the groin. And he later also developed hyperpigmented swellings that were itchy on the affected areas. Some of those swellings had a bloody and purulent discharge. So he had gone to several peripheral clinics where diagnoses like osteomyelitis, mycetoma had been made, and he had been treated with several oral antibiotics and antifungals. So as we had said, he's a non-hypertensive. He's on atenolol, telmisartan, and furosemide. So on examination, he was sick looking. Let me just take you a little in front. Okay, so on his general examination, he was sick looking and febrile, no jaundice with palpable right inguinal lymph nodes. He also had bilateral lower limb edema. And notably on the right lower limb, we had, so unfortunately the images taken were very few, and we focused mostly on the foot, but we should be able to appreciate some of the features. So, but as we can see, there's edema of that right foot, and we are also having these hyperpigmented nodules. And under the sole of the foot, you can see these erythematous nodules with yellowish crusting. So they also extend to right this area. Okay, still the same. So notably, the right side the swelling was more compared to the left foot. Okay, so we also came up with a diagnosis of Kaposi sarcoma with those differentials. And still we did a punch biopsy. So on histology, as we can see, the first image is a low power image. We can appreciate still the stratum corneum, the stratum granulosum, spinosum, and the stratum basale, which are all normal. Then notably, you can see the dermis is quite busy on low power. This is just an artifact. Okay, then this is also an artifact down here. So then we go to a high power image. So same things, we have a lot of endothelial proliferation, lots of slit-like vesicular spaces, extravasation of red blood cells. Then we have the hemosiderin deposits here. So also to note, in the low power image, if you see just the right, yeah, the right, just at the bottom here, there is sort of a nodule. So usually in case we have in the nodular type, we have the spindle cells lying parallel in forming sort of like fascicles. So that is what is happening here. So that is usually in the nodular type. So, and as we go to the next slide, we can see the extravasation of red blood cells, the hemosiderin deposits. As you can note also the way the spindle cells are in a parallel pattern there. Yes. Okay, still on the same patient, so the same things, just a little bit closer. And same thing, extravasation of red blood cells, the spindle cells, the hemosiderin deposits. Okay, so we go to our third case. This patient had bilateral lower limb swelling for 3 years, and he was HIV negative, 49 years old male. And this swelling had been accompanied with hyperpigmented swellings involving both the lower limbs, but mostly on the medial aspect of the thighs. So he had not had any prior treatments. However, he had been investigated from the National Cancer Unit, that is some kilometers away from here. But he reports, we did not have a look at the report, but he reports that they did not find anything. The tests, the results were inconclusive. So he had been referred to a dermatologist. So he had no non-chronic illnesses. He reported to be HIV seronegative, and he had no history of drinking alcohol or smoking tobacco. So on examination, he had enlarged bilateral inguinal lymph nodes and bilateral lower limb edema, but more significant on the right. He also had multiple black patches, plaques, nodules, and just to take you, let me go through that. So as we noted, the lesions were mostly on the medial aspect of the thighs, involving also the groin, and you see the significant edema of both limbs, but more on the right. So these were the legs. You notice the thickening of the skin, and on the right leg, we also have these nodules. So a punch biopsy was also taken off, and so quite, as we can see, there's an artifact here. On a higher power image, we have still significant endothelial proliferation. The slit-like spaces are not as prominent as the previous patient, but we can appreciate some of them. And to take you further to the next slide, we can see what looks like a promontory sign somewhere here. And on the next slide, we can also appreciate some extravasation. So, but as we can see, his signs seem to be quite subtle on histology. So we still came up with a diagnosis of endemic Kaposi sarcoma. We referred him to the oncology unit, and we also requested for those other laboratories that we needed. However, this patient, when we checked with the oncology unit, he did not actually reach there, and he has also not come back to us for review. We have tried reaching him via phone, and we are unable to reach him. So then we go to our next case, the similar history. This was a 31-year-old male, HIV seronegative, who came in with left lower limb swelling. He also had no non-chronic illnesses. However, he reported this swelling had been ongoing for 3 months, and it had also progressed similarly to the other cases, starting from the foot, then going all the way up to the brain. So this was associated with swellings, those hyperpigmented swellings, but in this case, we had ulceration of the swellings, and some of them were discharging a straw-colored discharge. He had also reported significant weight loss. There were no night sweats, fevers, or loss of appetite. So he had had inpatient management with antibiotics and wound dressing at his home district hospital. But however, there was no improvement. So on exam, his left lower limb was swollen. This was all the way from the foot to the thigh, and with thickening of the skin. Yes, so we can have a look at the slide there. So we have the swelling of the foot. It was going all the way up, but there's this thickening of the skin. We have nodules here, also some on the plantar aspect of the foot. So he had also on the distal thigh and proximal leg, we have these very big nodules with crust over them. What you see here, that is yellowish, that was metronidazole powder that had been applied at the peripheral clinic. So we also came up with the diagnosis of Kaposi sarcoma with those differentials, and did a number of tests. We started with a punch biopsy. So we look at the histology slide. So still similar findings, really, a lot of endothelial proliferation, some slit-like irregular vessels. Yeah, so, and we should be able to appreciate all that. So we also did other tests. We did a Hep B surface antigen test that was actually positive. We went on to do a hepatitis B viral load, which showed less than 20,000 international units. Yeah. So then we did an RCT that was actually negative, and the rest of the findings were normal other than the abdominal ultrasound that showed diffuse intra-abdominal lymphadenopathy. So for his treatment plan, we did wound debridement and dressing. Yes, for the diagnosis, we had endemic Kaposi sarcoma and hepatitis B. And for the treatment plan, we did the wound debridement and dressing. We also gave oral morphine, bisacodyl, flocamox, and was reviewed by the oncologist, who prescribed also paclitaxel at that dose and gave the pre-medications. So this patient was actually, he was able to complete all the 6 cycles of chemotherapy with no complaints during the course of treatment. At the end of chemotherapy, he had put on about 9 kilograms as compared to when he started the chemotherapy. However, after his last dose of chemotherapy, he passed on under unclear circumstances. That was 3 days after that last cycle. Okay, so thank you.
Thank you, Dr. Miria, for the review of cases. So now we want to look at the literature around Kaposi sarcoma. As the information that we know, there is a lot also that we don't know. Kaposi sarcoma is an angioproliferative cancer, as we have seen from the pictures of the slides, the histology slides. Endothelial proliferation all speaks for the angioproliferative nature of this cancer. It's rare in the general population, but it has increased with the incidence of HIV. And in sub-Saharan Africa, it has been known as the AIDS-defining cancer. However, there are declining instances of Kaposi sarcoma as we embrace the 95-95-95 strategy. That is, 95 people with HIV are tested or should know their HIV status. 95% of those should go on treatment, and 95% of those on treatment should have antiretroviral suppression. So with that strategy, we are having increasing cases of decreased viral load, and therefore subsequently other benefits come along with that. So that has improved the outcomes and prognosis of this carcinoma. The epidemiology of this condition is that prior to the advent of HIV/AIDS, Kaposi sarcoma was more frequent in Africa than the rest of the world. The epidemic of HIV further increased the incidence or the severity of this condition. And it's now apparently one of the most common cancers in Africa. Age-standardized incidence rates have showed that it's about 0.3 per 100,000 persons, whereas in 2020, we had about 34,000 new cases and about 15,000 deaths. In the Mbarara Regional Referral Hospital, this shows the profile of our cases through the years from 2020 to 2024. So we can see an average of around 32 cases of patients seen or reviewed at the regional referral unit. Risk factors for this condition is old age, HIV or immune suppression of any form, the Kaposi sarcoma associated herpes virus, which is HHV type 8, alcohol consumption, helminth infestation. Males are more at risk. We have had a case of hepatitis B, so should we also look at hepatitis B? And also there are some studies that have suggested the role of chronic malaria infection, especially for Kaposi sarcoma that is seen in children who are not infested, who are not infected by HIV. Something to look at, some of those risk factors. Kaposi sarcoma, the combination of ART, patients are on ART, the lesions usually stabilize, as has been noted in several studies, and ART further decreases the incidence of Kaposi sarcoma. It has also been recorded that about 20 to 80% may have total resolution of lesions. So from studies, especially those that do histology assessment, and from what we have seen also through the case presentations, there is proliferative vesicular lesions, and most of these, for those who do the serology titers for Kaposi sarcoma, have noted the Kaposi sarcoma associated herpes virus. And this is said to be lymphotrophic and angiotrophic. The genomes of this virus tend to encode for several proteins, such as the lytic genes that are responsible for proliferation and also have anti-apoptotic functions as well as inflammation. So there is a lot to do on the pathogenesis to further elucidate on the exact pathogenesis of Kaposi sarcoma. especially in the endemic forms. So the other forms, like the epidemic forms, there are several genes that have been identified, but for the endemic form, we still have a lot to do to be able to identify the exact pathology. So types of Kaposi sarcoma, there are 4 major types. We have number 1, epidemic or AIDS-associated Kaposi sarcoma, which we have already seen through the case presentations. We have the classic Kaposi sarcoma, which tends to occur mostly in the Mediterranean communities and the Asian communities. Classic Kaposi sarcoma is usually more common in men than it is in women. And it's often slow growing and most often affects only the legs. There is a similar form of Kaposi sarcoma that happens in Africa, especially for people who are not infected with HIV, which presents with similar characteristics as the classic Kaposi sarcoma, and probably it's what we call the endemic Kaposi sarcoma. And as we have said, in the older persons, it tends to be more less aggressive. And as I've said earlier, in children, there has been a possible suggestion that chronic malaria infections could be a big risk factor for children acquiring this form of Kaposi sarcoma. But in the older individuals, we don't have sufficient information on the exact etiology. Then lastly, we have the iatrogenic or transplant-related Kaposi sarcoma, which often develops in people whose immune systems have been compromised through organ transplant. One of the studies that was done here in Barara, and people were infected with HIV, it was noted the total number of patients that were studied was 68, and it was observed that 25% of the patients who were enrolled in this study died. And those who died, it was noted, had HIV for over 5 years, and they had very low CD4s. Patients who had started ART within 3 months of diagnosis had a better prognosis, whereas those who started later had poor prognosis. It was also observed that those who had Kaposi sarcoma involving other organs, such as the lungs or the GIT, had poor prognosis. Chemotherapy was observed to offer no benefit in those patients. The clinical features through the pictures mostly presents with nodules, papules, macules, and plaques, which may take on different colors, mostly red. They could be purple, violet, brown, or even black. They can occur mostly on the skin, but also in other places like the mouth, the GIT, and the respiratory tract. The lesions are usually painless, like we noted in most of our patients. But usually they are cosmetically disfiguring, and if the lesions occur in other organ places, they tend to disrupt function. These are some of the pictures that can be seen from other places other than our settings. So these are borrowed from elsewhere just to relate to other places. So you can see lesions, nodules here, the oral cavity, involving there the gingiva, lesions on the plant aspect of the food, can have violaceous Maya patches there, and a few nodules. Then you can have these red nodules. Could be prominent like that. You can have a few discrete lesions on the genitalia, and then you can have these blue-gray or gray lesions, which may look violet in some other people of fair skin, mostly on the extremities. And prominent edema, then you can have genital edema, and then the involvement of the limbs there. Investigations, For most of the patients who have the epidemic form of Kaposi sarcoma, we need to do CD4, and then we do the plasma HIV viral load. Because of the involvement of other organs, we need to rule out that. We can do chest radiograph, we can do thallium and gallium scans, we can do bronchoscopy, esophagogastroduodenoscopy. Those who can do MRI can do, as well as for us in our setting, the punch biopsy is very important. Treatment of Kaposi sarcoma for those AIDS, we have already said that with AIDS-associated Kaposi sarcoma, starting them on ART can come with the benefits up to the possibility of resolution of lesions. Then some lesions can be treated with surgery or radiation therapy or require surgery. For widespread lesions, especially if they also come with other system involvement and also lymphoedema, then we need to add on systemic therapy. And the available options are interferon alpha, doxorubicin, and vanorubicin. Thalidomide also, and in our setting, as we have noted, paclitaxel is quite available. Topical treatment, you can attempt to use erythritinoid gel if available. The challenges in our setting is that we have delays in confirming diagnosis, which results into patient loss to follow-up. Late diagnosis, which could be responsible for mortalities, is a big challenge for us. The cost of managing the disease is high, which may result in loss to follow-up, because the patients have to pay for imaging, lab investigations, and pre-medications. Notably, the only free drug available for our patients is paclitaxel. The risk factors for endemic Kaposi sarcoma have not been properly assessed in our setting, and therefore we cannot institute preventive measures that will help our patients in the community. Increasing cases of endemic Kaposi sarcoma as opposed to epidemic Kaposi sarcoma call for need to identify those risk factors. Way forward, we intend to do community awareness campaigns on Kaposi sarcoma so that our patients report to hospital early enough for diagnosis and treatment. We also tend to reduce the turnaround time for histology results. We shall have institute measures that we are able to easily follow up with our pathologists. Notably, we don't have a dermatopathologist, so we rely on general surgeons, general pathologists, but maybe we also need to hopefully push for further continuous medical education for our general pathologists to improve, to better their diagnostic skills on skin disorders. We recommend studies on risk factors for endemic Kaposi sarcoma, and we also intend to lobby for funds to enable our patients access funds for investigations, imaging, and medications, so that we improve on the loss to follow-up. Thank you very much. And we are grateful to LODAM, ILDS, and then Mbarara University for enabling us to participate in dermatology and also in this activity. Thank you very much. So colleagues, we welcome contributions to this presentation. We can listen to the issues that. Okay, so we can have we are having a conversation on the chat. The conversation on the chat.
I can read question and answer. Can you hear me?
Yes, we can hear you,
yes,
Dr.
we can hear you.
Dr. Sibali.
Question number 1. What are your experience with Kaposi sarcoma iris? Does it settle in time?
I did not. With pardon?
What are your experience
with the Kaposi Sarcoma iris? Does it settle in time? Are you
Okay,
able to hear the question?
Yes, we have picked your question, Dr. Sibali. Our experience with the Kaposi Sarcoma and the iris is that what we have noted is that ARVs tend to improve the profile and they offer benefit to these patients that have Kaposi Sarcoma and HIV. However, as we have reported from one of the studies that was done in Barara for the 68 patients that were in the study, it was observed that treatment modifications were not of benefit for individuals that reported late. So those who were diagnosed earlier, the benefits are better as compared to those who are diagnosed late. There is some bit of benefit, but the time of diagnosis of HIV and Kaposi Sarcoma determine the prognosis.
Okay, the second question. In your experience, how often do you need to use non-conventional chemotherapy and HERT in management of patients with HIV and Kaposi Sarcoma?
Yes, the indications of chemotherapy will depend on whether there is organ involvement or if there is lymphoedema. If you have lymphoedema and organ involvement, that's a big indication for the patients to start chemotherapy. But for those who have less advanced forms of Kaposi Sarcoma, in some situations, HERT is sufficient.
Thank you, Dr. Mirembe. The third question, how common is endemic Kaposis in your setup? Do you manage it differently than the HIV-associated type? How would you compare the morbidity and mortality in the two groups in your setup?
Okay. So endemic Kaposi Sarcoma, as we have noted, used to be the most prevalent form before the HIV epidemic. And then for some time, the epidemic Kaposi Sarcoma has been the most prevalent. But now we are beginning to see more cases of endemic Kaposi Sarcoma and decreasing cases of Kaposi Sarcoma. And we think this is attributed to a big number of people being on ARVs. And we think they are effective and they're offering protective purposes there. So we think now we have increasing numbers of endemic Kaposi Sarcoma, and therefore, but we don't have the statistics yet. So we do not have recent statistics to base on to give the exact prevalence of that. Maybe that remains as a recommendation to do a study. Then in the management of endemic Kaposi Sarcoma, definitely we shall not put the patients on HERT, but we shall start chemotherapy. As indicated in our setting, we have paclitaxel available. And also other treatment options remain open, like cryosurgery and radiotherapy. So all those treatment options remain available for those patients. There's the morbidity. The morbidity and the mortality tends not to be affected by the forms of the risk factors. As long as one has Kaposi Sarcoma, the severity is what will determine the prognosis of that patient, regardless of whether it is Kaposi Sarcoma, HIV associated herpes virus, or endemicity or any other forms.
Thank you for the answer. The fourth question, for iatrogenic Kaposi sarcoma, how do you minimize risk while maintaining adequate immunosuppression? Is there any specific surveillance tool to detect Kaposi in such cases?
Okay, maybe the biggest risk there for people who are who are iatrogenic Kaposi sarcoma is that they are under immunotherapy, immune suppressive therapy. So that, and it's a requirement. So they cannot be denied that treatment option. So the other thing that we can possibly do is to investigate for to do the titers for Kaposi sarcoma associated herpes virus in those patients, and if possible, we can assess the possible combined risk in those patients. But otherwise, they still need the immune suppressive therapy, and probably the thing is to make sure that the organ takes, and then we are able to take them away from immune suppression.
Usually when the immune suppression is taken off, then they're able to actually get better without need for anything, any other intervention.
The prognosis is better when the immune suppressive therapy is stopped.
Is there any specific surveillance tool?
No, we don't have one yet. It's probably something we can consider.
So who pays for the treatment and medication?
So it's the patients actually who pay for the treatments. It's only, I think, the paclitaxel is the only one that the hospital is able to offer. However, the pre-medications, any investigations, any imaging is all paid for by the patient.
Thank you. Those are the questions being asked.
Thank you very much.
Thank you.
Thank you to our presenters, Dr. Mirembe and Dr. Miria. And thank you for everyone that turned up to our today GLODEM webinar session. So in case you have not followed us, please follow us on social media and subscribe to our mailing list. So you get to be the first to hear about our next sessions. Thank you so much, and I'm happy that we finished on time.